Everybody, so we have a very special guest here with us now. A little nervous because what she's going to say I think is, important. So tell us your name first.
Zoe.
Okay, Zoe. And what do you do?
I'm a medical coder.
And what does that mean?
I call it the central intelligence of the hospital, or the SimCity level view. What it is you look at medical records, every kind of medical record, all the diagnostics, and you take that information and you put it into a code which goes to insurance, and that's how hospitals and physicians get paid. So if I do my job right, then the physician and the hospital make the most money and they don't get sued for fraud.
Okay, we have to start with what on earth went on with the hospital COVID protocols, because we've had more stories of that than anything else as we've traveled around. So what were you seeing?
I noticed there was hardly any patients when they called the emergency pandemic, and there was 2 weeks to flatten the curve. We didn't have patients in the hospital at that time. They slowly started to trickle in, maybe after months and months of that. We were told to basically create beds for hospitals with the executive orders, which meant we sent patients home before they were actually ready to go home, which we had never done before because that's a financial liability. We could actually, if patients come back, we would have to pay for their care. It's a Medicare rule. So that was definitely very different. There was some financial stuff that happened because in April they had a code update, which they'd never done before. They had to come up with a way to track COVID. So it was all about tracking the disease, tracking COVID. And the code system is supposed to be the main tracking system. So no one had any standardized practice. Even our hospital said there's no standardized case number, so we can't even tell what's going on, even though there had already been declared an emergency, and you could see the HHS and the WHO and all of those case maps that showed us all the outbreaks. Well, it definitely didn't match up with what we were seeing in the hospital, and even the admin admitted that. So they created their own map. So that was sort of why the COVID diagnosis came out. But that's when the bonuses came out too. They had to have that diagnosis in order to get the 20% bonus for COVID patients. So any patient that was admitted that had a COVID diagnosis, they got a 20% bonus for that. If they were put on Remdesivir, that was a new technology, and new tech codes can apply for an additional 20% bonus in payment because of the risk of an unproven technology. So Remdesivir, Gilead had actually applied for a new tech bonus payment for Remdesivir. So the new code was created for Remdesivir in April. And that's actually what launched the hospital protocols, because people were actually doing well when they were treating them with hydrochloroquine, which came from Operation Warp Speed actually, and the national stockpile of hydroxychloroquine. Hospitals got a free donation of that right at the end of March, and then 3 days later, a few days later, April 1st, the new diagnosis came out, the bonus for Remdesivir came out, and it was like a line in the sand. We stopped azithromycin and hydroxychloroquine, and we went straight to Remdesivir where we got the bonus. And then of course we got a 20% bonus for putting patients on a ventilator also. And so also the other part of that was the PCR tests. So I noticed that I actually worked in a hospital university lab for a long time. My mom was a medical technologist. That was her profession my whole life. And I had actually run at one point the rapid, they used to call it a rapid flu test way back in 2004 when I was working in a lab. And that was the prototype for the COVID-19 PCR test. It's basically a PCR test, but it's not quite the same methodology of how you do the cycle threshold thing. So when the COVID-19 test came out, there was a whole thing that happened with that too. And that sort of came with bonuses and incentives also that were not super easy to see on the surface. But what happened was the CARES Act provided money for all the COVID-19 PCR testing. So normally testing costs hospitals money, and so they don't like to do a whole lot of diagnostic testing to identify a virus or do cultures or anything necessarily. They actually start treatment before they know what pathogen they're dealing with, and then they may do identification later after they start an antibiotic or whatever, preliminary treatment they're going to do. And initially with PCR tests, I don't know if you remember, but they had tents set out where people could go and get PCR testing, but you had to have symptoms at that time. You couldn't just, they were saying there was like a shortage of testing. And it took, I don't know, maybe a month or so until they started screening everybody. Well, when they went from you had to have symptoms to get the PCR test, there was hardly any patients that had it. And then when they switched to now it's readily available, the CDC says that every hospital can do their own testing. And so we brought it in-house, and hospitals didn't have to send it to a different lab and wait a week to get the results back. Then we could do it all the time. So then 80% of our patient population became COVID positive, whether they had symptoms or not. And that had never happened before, that we had never used that test as a screen before. It had always been like a confirmatory test, like you had to have symptoms, and the doctor had to not know which kind of disease they were dealing with, and then they do some sort of test to figure out why aren't you getting better with the treatment. So that policy completely changed, and there was a bonus to getting the COVID patients. So that's ultimately...
We had people telling us they'd go in for, I don't know, a broken leg or something completely different, and then they would be, before they knew it, on a COVID ward, because they would... And then we had a nurse telling us also...
Yeah, because they would screen patients in the hospital for COVID. They would come in for a gallbladder removal or broken leg or a motorcycle accident or car accident or anything else. And while they were in the hospital, they would do this screen. And if they came up COVID-19 positive, that's when they would start the treatment. And they would put them on the ventilator fairly soon. They would start the Remdesivir, and then they would have kidney failure and pulmonary edema, and they would just circle the drain, and it was like nothing that the hospital could do would save them. I've never seen anything like that. That is not how a normal flu case would progress, and that's not how a normal pneumonia case would progress. Before 2020, if patients came into the hospital with the flu or with pneumonia, they would tend to get better within 3 days and go home. Hardly ever would we have an inpatient admission for flu. Pneumonia, yes. Flu, almost never. And if they did, I mean, they were elderly and they had a lot of other things like organ failure or heart failure or cancer going on, and flu was just the last thing that was going on after a bunch of other things. It wasn't just flu, but for COVID, at first it was elderly patients, and then that I noticed that had symptoms, and then it started to get to be younger and younger people that actually had symptoms, because I wasn't even paying attention anymore to if they were COVID positive or not. I was paying attention to, did this patient come into the hospital with symptoms? Did they have some sort of cold or flu type thing or pneumonia type thing going on before they came into the hospital? Because at some point the hospital sent out, like we have, whether you work on site or whether you work remote in almost any hospital, they have some sort of like an intranet for employees, and it's like your very own homepage that everyone sees when you log in every time you go to the computer. So that's where they put the messaging. The leaders put the messaging. So that's where like our case chart would be, how many COVID cases we had. At one point, they sent out a message that said the FiO2 settings on the ventilators had been killing people, and we don't know how to treat COVID, so we were trying these ventilator settings thinking that that was how we were going to treat COVID, but apparently the FiO2 setting was actually killing people on the vents. So we're going to stop doing that. We learned that was not working, and so we're going to adjust it, and we're sorry. And I was shocked by that, because I had already started to hear rumors that patients were being killed on ventilators in the hospital, which made sense to me because we had never had a flu case or a pneumonia case where someone's on a vent for a month and we can't save them. That had never happened before. Usually maybe 24 to 48 hours, and they're talking let's pull the plug, or get them out of the hospital and get them into some long-term nursing care setting.
Okay, let's just go back a little bit. I want to go back to the PCR test. We had a nurse on this bus telling us that a patient would come in and they would be told from above, whoever that above person is, to keep testing until they got a positive.
Yeah, they did that. It was like they were playing roulette. And the doctors would even put in the documentation, I don't understand this. It's like the patient doesn't have anything I can treat. I keep doing the PCR test. It keeps coming up positive, and they have nothing wrong, and that would happen. They would do like 6, 7, 8 tests, and it would be positive, but the patient would have nothing wrong with them, and the doctor would be really confused. Sometimes they would do 4 or 5 tests, and they would get a bunch of negatives, and then they would get one positive, and they would take the positive and then treat the patient for COVID. So it was like playing roulette. They would just, even the different doctors were documenting, I'm not sure I trust this test. So let's just run it again and see what I get this time.
Now let's talk about Remdesivir. Talk me through once more how we came to be prescribing an emergency use authorization thing for people with COVID that shuts down their organs, which is what we've been hearing over and over again.
It was really interesting. I don't know how it came to be approved. I wasn't privy to that. I looked it up later. But when the new diagnosis code came out, and also the code for Remdesivir, which created the 20% bonus for it, we started prescribing it. And the hospital had a protocol about Remdesivir. They knew that it caused kidney damage. It said right up front it causes kidney damage. But the thing is, all the propaganda, and I call it propaganda intentionally, was saying COVID-19 also causes kidney failure. And in the hospital, kidney failure is a very common thing. We call it AKI, or acute kidney injury. And so that was something that we saw every day. It was normal, a normal thing that we would treat. So it would be normal for us to see that and think, well, we're just dealing with kidney failure. It's just something that happens to people sometimes. And especially when they started programming us with, well, COVID causes kidney failure. But Remdesivir also caused kidney failure. And they had to do an infectious disease consult and a renal consult before a patient could go on Remdesivir. And if they had chronic kidney disease stage 3 or higher, they would be disqualified from receiving Remdesivir. And we had to document like a permission slip and an informed consent form and put that all in their medical record. And then they would administer the Remdesivir. And sometimes there was one dose, sometimes there was a few doses, but they all ended up with kidney failure within a few days. Some patients ended up going home with home dialysis prescriptions. Some patients ended up on a kidney transplant list. Some patients ended up with chronic kidney disease after they were given Remdesivir, if they survived. And a lot of patients ended up with COVID pneumonia, which is apparently Remdesivir causes the kidneys to shut down. And when the kidneys shut down, they regulate fluid levels. And when you can't get rid of fluid in the body, it builds up, and it comes up from the abdomen area, and then it goes through the diaphragm, and it can get into the lungs, which we were calling pleural effusions, or which we also, on an x-ray, it looks like what we would call pneumonia. So we called it COVID pneumonia, but if you look at the chest x-ray of a patient with pulmonary edema versus COVID pneumonia, they're almost identical. And providers, even though they knew Remdesivir had this risk to the kidneys, they never connected that might be causing patients to have kidney failure after they administered it. They just thought it was COVID.
But it's just the money. I mean, the minute they saw they got bonuses from the PCR tests and everything.
Yeah.
It was money. It was the money. It changed. The whole thing changed.
The whole thing, yeah.
Right, I have to ask you another question. So we've had hundreds of COVID protocol deaths situations, and you're sitting in the memorial right now, and you can see them all.
I know.
They're all unvaccinated. So this is the thing we're trying to get to the bottom of. We have people that come in, and the first thing they're asked in hospital is, are you vaccinated or unvaccinated? In other words, did you take the COVID shot or did you not?
They weren't asking that in my hospital. It was almost impossible to figure out at first. It was like they didn't want us to know. They didn't. And I know from the medical coding thing, working with emergency room, that one of the things that we need to gather information on is if a patient was injured, where did that come from? There's actually a code for that. If there's a side effect of a vaccine, there's supposed to be a code for which vaccine the injury came from. And that's how they can look it up, like researchers can look it up as part of a study. If you know which code to look for, you can pull every medical record that has that particular symptom with that cause. And you can put a study together with that information. You can solicit the CDC or the WHO to get that data. That's the whole point of coding internationally, is to capture that data. but they weren't asking that on the front end at first. It was almost impossible for me to find out. I had to look into the notes. I had to go through literally 40, 50 pages sometimes of notes to find where the patient told the nurse or the doctor, I received the COVID vaccine.
Let me go back to where we were, what people are saying. They're saying that they're going in, the first thing they're asked is if they've taken the COVID shot or not. If they have taken the COVID shot, they go one way. If they haven't taken the COVID shot, they go another way. And this is hundreds and hundreds of people saying the same thing in different states. So there's something going on. So the ones that are not vaccinated get taken straight into a COVID ward, Remdesivir event, death. Very few got out of that. The vaccinated, some of them do get Remdesivir, but they never seem to die. They get sent home, or maybe they die at home of something else, but they're not killed by the hospital protocols in hospital. That's what we've seen. And one nurse came and told us that when there was a death from the unvaccinated, there was no drop down to put in that this was an unvaccinated.
I had heard that too, and I had heard that that was in the EPIC system, and that's what I worked with. I actually worked in the EPIC system, like in the hospital, helping to develop that and figure out, which kind of things do we want to prompt the doctor to put in the medical record. That was part of my job. So totally understand, and I had heard that nurse actually give that testimony, and I can totally believe that. However, I wonder when that switch happened, because I quit working for the hospital in April of 2021 over the vaccine mandates. I would not be vaccinated, and I would not be PCR tested, and they were even starting to put propaganda in the hospital, messaging on the internet saying it's you that's the problem, you're working from home, you never see patients, but you're the one giving COVID to grandma, so you need to get vaccinated. And there's a Medicare incentive that they actually get money if they vaccinate their staff, and there's a massive amount of money they would lose out on if they didn't vaccinate their staff, so they were incentivized to say that. And I knew I wasn't going to be able to get an exemption, so I quit at that time. That was pretty early on. They might have switched it after that, because I feel like so the vaccine went out in January, or December 6th, actually. December 6th, 2020 was when my hospital started giving out the vaccine through the drive-through. And then I quit in April 2021. So that was only a 4-month period. And during that time, they didn't have drop downs. They didn't have a questionnaire, because that's something that I would have had to look at in my everyday job, because I had to identify, is this patient COVID positive? Are they not? And I had to look at, every single record that I put that on. Our hospital wanted us to verify that.
So do you believe that the people are saying that their loved ones were killed in hospitals with the COVID protocol, and that should never have happened, obviously? Do you believe them?
100%. I knew they were killing people. I knew they were killing people in the hospital. I would cry myself to sleep at night, even thinking about giving my speech today. Sorry. There was so much death. It was almost unbearable. Hospitals became the place where people go to die instead of the place where people go to get better. They separated newborns from their moms. They let people die alone without being able to say goodbye. They drugged them and they strapped them down, and people died without being able to say goodbye to their family. Some of them just got a phone call. Some of them didn't get anything. Some of them just weirdly died in the middle of the night when there was a skeleton crew on, and they had been doing fine up until that point. And then just all of a sudden, overnight, they crashed. I don't know what happened. And that had never happened before the COVID protocol rolled out in 2020. So yeah, when they say they killed people, I agree with them. And I told people from probably April on, don't go to the hospital. They're killing people in there. Stay away. I don't know what's wrong. I didn't know what was doing it. I honestly didn't know it was the vents. I didn't know it was the Remdesivir until I looked into it later, and I was able to kind of connect all the dots. But I knew they were killing people.
What about vaccine injury? The ones that actually took the shots, what did you see there?
Massive. I didn't know it was possible for a human to die so horrifically and so quickly before they rolled out the mRNA injections. It was insane. I've never seen anything like that. The worst of them were the ones, they called it sepsis, but it was like instant multi-organ failure. Like within hours, patients would die of liver, lung, kidney, all at once failure, respiratory failure. It was like some of the records, the emergency crew that found them, it's like their body tried to reject everything, and some of these cases, like their family would be there 30 minutes before, and then within an hour they're dead. And then there were patients coming in with seizures like I've never seen before. We couldn't control some of them. Days patients would be seizing, and no medications would stop it, and eventually they kind of had to be put down. They called it encephalitis or encephalopathy, and then later on even the coding information organization AHIMA admitted COVID-19 associated encephalitis. There were blood clots, strokes. The clots were insane. Never seen clots like that before. Even the interventional radiologists that were going in with, they have angiopathies and, different scopes where they can do like heart interventions and put stents in like a carotid artery if you have a stroke going to your brain. Normally it's rare to have more than one stent go in. And they were documenting, multiple locations all at once. They had heart attack cases that were like that, where they needed massive amounts of stents that they never needed before. There were people in their 20s that had been hiking that were totally healthy, had been running marathons, that suddenly needed a leg amputated because they had a massive blood clot going from their hip all the way down to their leg, and it couldn't be saved. So that happened. There were some cases of overnight spinal gangrene, which I've never seen before. And you can't amputate, the spine when it goes gangrenous. Normally they cut out tissue that's dying like that, so it prevents further infection. And they didn't know what to do. The only thing they could do was, basically replace that part of your spine with an implant. That's the best they could do. It was really intense. And I didn't question the vaccines as much as I should have. I started to about the flu shot way back in 2004. But with the pressure to get the COVID-19 shot, I started looking into what it could do, and I knew I didn't want anything to do with this experimental mRNA thing. And when I started looking into the experts that were saying, well, this is what this potential vaccine could do, this is what the research says, I was looking at the vaccine trials and what was happening to those patients, and the Guillain-Barré that was happening, and the strokes that were happening, and so I kind of knew to look for that when the vaccine came out. And the doctors were, baffled. They weren't connecting the dots. But to me, knowing what the potential causes or potential symptoms of a vaccine injury could be, we 100% had all of the things that I just described. But doctors would never tell you that. They would just say it's a stroke, it's a heart attack, it's a blood clot, and they would never connect the two.
Is there anything that would make you take a vaccination of any kind ever again?
They would have to kill me. Nothing. Nothing would make me take it. Not any more kinds. No more vaccines. Nope, I've never had COVID.
Or flu or whatever.
No, I had a cold once in 4 years. I call it a cold because it felt just like a cold. I didn't have I lost my sense of smell. It felt I wasn't even really down that bad. I just, got the sniffles for a couple days. Really, it wasn't that bad. But I take zinc and vitamin C and glutathione every day, and I eat clean, try and take care of myself. So,
is there anything else you want to add to the story? Anything else you want to say?
I don't know.
Would you take someone you love into hospital?
No. Not any, I mean, that's a really hard question, because I want to say 100% no, but there are some exceptions where, you know, if you have a massive injury where your arm's broken, you know, like a holistic doctor isn't going to be able to set it in the same way depending on what kind of a break it is. They might not be able to do the diagnostics, but them coming at me with a needle of any kind, I don't really trust it. I don't trust PCR tests. I'm not going to let a doctor try and diagnose me based on that. I would have to know the doctor or the care team, that hospital. I would have to vet them, and my dad's, you know, probably going to need care soon. So I'm working as best I can to try and keep him at home.
Are you employed again?
No, I have not worked in 3 years. I have tried not to go back into healthcare because I knew I wasn't going to get an exemption, and I mean. I'm kind of trying to go back into it now, and they're still requiring, it even says right in some of the job descriptions that COVID-19 is still going to be required, and there are very limited exemptions allowed, and then all the other vaccines are still required. So probably not a good chance that I would get a job in healthcare if that's part of it. I wanted to grow food and maybe work with animals like I did before I went into healthcare, but that's been really hard to get into. There's not a lot out there, and I'm a woman, so apparently I'm the wrong gender to start farming or working with animals or growing vegetables.
Well,
I don't know.
That. We'll start. Listen, thank you for being so brave. And is this the first time you've spoken publicly about this?
Yes.
Thank you for doing that. It's very important information you've given us. We truly appreciate it. Thank you.
Thanks.